Welcome to the Radiation Injury Treatment Network's Just-in-Time training, designed to give you answers to questions you may have about treating patients with acute radiation syndrome. I'm Neil Hansen, and I practice diagnostic radiology and nuclear medicine at the University of Nebraska, and have served as the director of our Radiation Emergency Health Center here for several years. Acute Radiation Syndrome, or ARS, is a life-threatening illness which occurs when most or all of a person's body is exposed to a large dose of penetrating radiation within a span of minutes to hours. Because you cannot see or feel radiation, the victim will not accurately know their level of exposure. The unit for radiation measurement is the gray, and typically an ARS victim will have been exposed to more than one gray. For reference, one gray is equal to approximately 100 pelvic CT scans. There are three classic subsyndromes within ARS. The first is the hematopoietic or bone marrow syndrome. This can start occurring around 1 to 2 gray of radiation. The primary cause is destruction of bone marrow, resulting in infection and hemorrhage. The second subsyndrome of ARS, which is typically at higher dose exposures, is the gastrointestinal subsyndrome. Increasing rates of exposure associated with this syndrome are associated with decreasing survival rates. Irreparable damage to the GI tract can occur, along with bone marrow destruction, resulting in infection, dehydration, and electrolyte imbalance. Death can occur within 2 weeks. The neurovascular subsyndrome is the third subsyndrome of ARS and occurs at extremely high radiation exposures. Death can occur within 3 days, secondary to collapse of the circulatory system and elevated intracranial pressure. For all the ARS subsyndromes, the patient goes through 4 clinical phases. The first phase is the prodromal phase and is characterized by nausea, vomiting, diarrhea, and general malaise. The onset can occur within minutes or after hours, depending upon exposure level. The higher the exposure level, the sooner the time for symptom onset. The symptoms in this phase may last for a few days. Latency is the next clinical phase. The patient is generally asymptomatic during this transitional phase. The patient feels normal and seems healthy. The latent phase can last several weeks, but may be shorter with higher levels of radiation exposure. Manifest illness is the third phase of ARS, with overt clinical manifestations, including low blood cell counts, bleeding, diarrhea, and electrolyte imbalances. Altered mental status and shock can occur. For lower levels of exposure, this phase may not occur for weeks. Eventually, the person will either recover or die. Whether they recover or not depends on their original exposure level, as well as whether they were able to receive specialized medical care up to the complexity of a bone marrow transplant. Now, let's talk about treating ARS. How do we start treatment for a patient that is suspected of having had a significant radiation exposure? The patient's immediate medical needs always come first. If there is an acute traumatic injury, the immediate care needs for the traumatic injury take precedent. ARS typically occurs over a period of hours or days to weeks. It can wait until the patient is stabilized. When the patient is medically stable, they should be surveyed by your radiation safety or nuclear medicine personnel for radioactive contamination. For more information about medical personnel safety and decontaminating patients, see the MI-Safe video in this RITN series. Once all this is done, we must triage patient care according to estimated dose exposure. We have several ways to estimate how much radiation an individual received. The first is to determine how long it took them to vomit. The second way is to monitor serial blood counts, and the third way is to complete a Dicentric Chromosome assay. Timing the onset of vomiting after exposure can provide a rapid clinical estimate of the potential dose received. As people vomit for a variety of reasons unrelated to radiation, this method is imperfect. Though in general, the higher the radiation dose, the sooner the onset and greater the severity of vomiting. Not all patients exposed to radiation will vomit at lower dose levels, but if vomiting occurs, it is important to document the time of onset. It's also important to document the onset of other symptoms, including anorexia, diarrhea, fatigue, headache, and any other symptoms that may be part of the early prodromal stage. On the Radiation Emergency Medical Management, or REM, website, there is a useful calculator that can be used to estimate radiation dose from time to vomiting onset. This can be used for initial triage. The second exposure estimation method is to look at blood cell counts. White blood cells are highly radiosensitive, and they become depleted rapidly after significant radiation exposure. Their level of depletion can more accurately estimate the amount of radiation an individual received. Collecting serial complete blood counts and monitoring them over time is a valuable tool to estimate severity of exposure. A CBC with differential should be obtained as soon as possible and serially every 6 to 12 hours for at least 3 samples, and then daily. The REM website also provides an estimated dose calculator based on white blood cell counts. The third radiation dose estimation method, the Dicentric Chromosome assay, is considered the gold standard. It's a sensitive test that can detect exposures down to 1/10 of a gray. However, it is only done at a few centers nationwide. Given it takes days for results, most triaging of ARS patients will need to occur before these results are available. This chart provides an excellent summary of the clinical and laboratory findings in ARS patients for given exposure levels. You can also go into the REM website and plug individual patient numbers and symptoms into the calculator to estimate exposure. In a mass casualty incident involving radiation, the provider must have a radiation dose estimate to triage and determine treatment path. Why? Because at one end of the spectrum, a patient with a mild dose could self-monitor and recover at their local site or home. At the other extreme, if you know the dose received is above the threshold for survival, patients can remain local for comfort and palliative care. A patient with a radiation dose between these two extremes needs to be sent to one of the RITN centers to have access to dedicated subspecialty care. In this video, we have mostly discussed patients with external radiation exposures. Internal radioactive exposure, such as from inhalation, ingestion, or poisoning, is much more difficult to detect, diagnose, and treat. The Radiation Emergency Assistance Center training site, REACS, can provide guidance on acute medications for suspected internal exposure. More sophisticated tools can be used to limit the victim's radiation dose from internal contamination with their help. They are available via emergency phone 24/7, 365. The RITN website is another excellent resource that can be utilized for online calculators, detailed online training, and treatment and triage guides. The treatment, triage, and training tabs will guide you to all the online tools, as well as provide more detailed instructions to supplement this training. Important links can be found there as well. I hope this just-in-time training is helpful as you prepare to treat patients potentially exposed to radiation. These basics will assist in identifying and triaging patients appropriately while staying safe.